Hello, and welcome to today's webinar, Are Healthcare Professionals Ready to Address Patient Substance Use and Mental Health Disorders? I'm Tracy McPherson, and I will be one of your webinar presenters today and your moderator. I'm a senior research scientist at NORC at the University of Chicago, and I am also the lead investigator on our adolescent screening, brief intervention, and referral to treatment project that you're going to learn a little bit more about later. I provided my contact information for you in case you have questions about this webinar or any webinar in our series, or the work that we do around screening and brief intervention. You're welcome to email me at any time. This webinar is produced in partnership with NORC, the Adolescent Expert Project, the Brief Intervention Group Initiative, and our partner Cognito, who you're going to be hearing more from today. Our work is sponsored by the Conrad and Hilton Foundation. I would encourage you to learn more about our work and the work of our partners and our sponsor at our website, expert.webs.com. And you're welcome to email our team at expertteam@norc.org. This webinar is one of a series that we are hosting for you. We have a number of really important topics that I want to share with you, and I hope that you will take advantage of. Each one of these will be offered 3 times, so you have many opportunities to be able to attend and learn more about important topics such as brief screening tools, some very new tools that you may not be familiar with that are more emerging on the scene. We also will be talking about the integration of suicide prevention in the SBIRT model. And of course, we talk a lot about preparing the workforce and workforce readiness. So we have a couple in our series focused on that topic. And we'll be learning more about addressing opioid use among adolescents and young adults. And of course, we want to learn more about the contemporary trends in prevention and treatment, looking at risk factors for adolescent substance use and bringing you some of the more current literature. You can download the flyer and share that flyer with any of your colleagues at our expert.webs.com website /webinars, or you can download directly from the PowerPoint. Materials for today's webinar are available on our website. We have a dedicated web page specifically for this webinar. So expert.webs.com /preparing the workforce will house all the PowerPoints, materials and resources, and all of the on-demand access that you need 24/7. And this is where you can request a certificate of attendance, and you will have links to the evaluation survey. You'll be able to ask questions in today's webinar. There is a GoToWebinar pane, typically up in the right-hand corner, where you can click on the questions pane. This is where you can enter your questions at any time during the webinar. You go ahead and get them in early, and at the end of the webinar, we'll have a dedicated time, and we'll take as many of those as we can. If we're not able to address all of them, we will try to follow up and post those questions and answers on our website. Okay, so I'd like to get started first by setting the stage a little bit about our work under the Conrad and Hilton Foundation, and our work with Cognito and our partners. So this is a very large national workforce development initiative. We've really been focused on integrating adolescent and young adult SBIRT into social work and nursing education, and growing up the adoption of practice by social work and nursing professionals in a variety of settings where adolescents may receive care. I'd also like to note about this initiative is that as we've expanded this work, we've really come to really include additional disciplines. So we're really emerging into interprofessional practice and having social work and nursing education programs partner with counseling or another discipline to help expand the reach of the education to students, educators, preceptors, field instructors in a variety of disciplines. This particular initiative, in addition to the partners that I've already mentioned, we've been working with the American Association of Colleges of Nursing, the Council on Social Work Education, and the Center for Clinical Social Work to not only launch a national initiative, but to build materials and develop curriculum that really can be easily and readily available for integrating both in academic programs, but also in practice in a range of settings. So this initiative launched in 2014, and we are currently in our 4th year, and we will be continuing our initiative to 2021 and hopefully beyond. Over the last few years, we have put together a very robust committee of experts and researchers and educators and representatives from healthcare organizations and associations to help inform the initiative, steer the initiative, inform the development of all of the training materials that are available. This has been really key in making sure we're bringing together the right folks to build consensus and to really come sort of behind a common curriculum that can be integrated in a variety of settings. We also have a learning collaborative, a community of more than 70 plus nursing, social work, and other interprofessional schools and programs. That learning collaborative has grown to include educators and field instructors and supervisors and out in the field and preceptors and practitioners. So this is, again, an expansion really of trying to bring both pre-service education or pre-professional education and the current workforce education into one initiative. And now we're expanding our partnerships to include practicing professionals, working with leading professional associations in adolescent health and substance use, and trying to move that more into kind of mainstream workforce development at a professional level. If you're interested in joining our Learning Collaborative or just getting our monthly newsletter focused on this topic, you can visit our website, espert.webs.com, and you can go to the Learning Collaborative tab where you'll see that there's a link to be able to join. This initiative, not only have we expanded our reach across the country, as you can see by our engagement map, we have disseminated the curriculum materials and toolkit to more than 1,000 different organizations and programs. We've trained we're definitely well over 5,000 now in simulation-based learning with our SBI with adolescents simulation developed in collaboration with Cognito. And in terms of sort of in-person classroom workshop-based training, we've brought this training to over 10,000 at this point, and that number is certainly sure to grow over the next couple of years. Our programs and our community partners through this initiative not only receive access to the adolescent expert curriculum and toolkit materials through our implementation and evaluation tracks. We offer access to SBI with Adolescents online simulation, and we provide technical assistance around implementation and evaluation through telephonic technical assistance, a lot of email exchanges and reviewing of materials and that kind of support. And it provides access to a learning community at whatever level folks want to participate to really learn from others about what they're doing. And we can help match you with folks who are doing something similar so you can learn from them and hopefully make that learning curve less steep or learn some strategies for overcoming barriers. And it also offers the opportunity to have access to subject matter experts and expert trainers that you may want to bring into your site. I'd like to get, just to make sure that we're all on the same page. I know many of you are familiar with SBIRT and the SBIRT model. Some of you may be more new to it. I just want to provide kind of an overview, very, very high level, to make sure we're all on the same page about what we think of as upscreening and brief intervention in the model. And let's talk to you a little bit about the need to prepare the workforce and where SBIRT is happening in practice. So we use the SAMHSA definition of SBIRT as a comprehensive integrated public health approach to the delivery of early intervention and treatment services for people with substance use disorders. And what I think is most important about this statement is, and those at risk for developing them, identifying folks who are not, do not meet criteria for substance use disorder, but which historically we may not have intervened with. And this is the upstream approach to really identifying folks at risk. And in the curriculum materials that we have and those training resources, and we really go through and think of the model as starting with screening and early identification, really providing a lot of tools around early identification around alcohol, tobacco, marijuana use, non-medical use of prescription medications, et cetera. We also have tools related to other risk factors, risk for depression, for suicide. And the screening tools are really designed to help determine whether the adolescent is at a particular level of risk, whether it's more low risk or no risk, or it's sort of a moderate or high risk. And the curriculum materials help prepare professionals to know at what level of intervention is warranted when working with an adolescent in terms of making sure we have the right touch. Is it congratulatory feedback and building awareness? Is it something more robust and looking at a kind of a three model brief intervention, or is it a model like brief treatment where you're doing multiple brief interventions over time beyond 3 sessions? The curriculum materials go into the model at great depth, and I'll show you some screenshots of what we have available to you. And then also the referral to treatment. Well, I like to call this referral to a higher level of care or other services, plus follow-up and continuing to stay with that adolescent over time. So that's the model from which we have grounded ourselves, in which we've built this initiative and the materials. The purpose of integrating SBIRT into healthcare for adolescents, young adults, is increasing early identification of at-risk substance use and, of course, identifying those who might be at risk for a substance use disorder, building awareness and educating on the guidelines around alcohol and other drug use and risks associated with those substances. You want to be motivating those at risk to reduce unhealthy and risky substance use and adopt more health-promoting alternative healthy behaviors, and to motivate folks to seek help and engaging parents and caregivers when we can to seek help and to increase access to care for those who may have a substance use disorder who are at risk for developing one. And of course, the purpose is to foster that continuum of care from integrating prevention, intervention, and treatment, and really addressing substance use as a part of addressing the whole health of the adolescents and adults that we work with. Some of the places where I've observed SBIRT being integrated, and I welcome folks to share with us if there are other places that you're seeing SBIRT integrated into care. Of course, we're seeing it in primary care and trauma and emergency departments is where many of the more earlier work with adults actually emerged. We're seeing it in inpatient, hospital inpatient. Of course, a lot of work has been done in colleges, NIAAA, using the basics model, and there's still today a lot of work going on in higher education. We are seeing a lot of movement in school-based health centers in fact, the Conrad Hilton Foundation is supporting a large initiative with school-based health centers with the School-Based Health Alliance. Of course, we've seen a lot with federally qualified health centers, community mental health centers, community-based programs, juvenile justice, and believe it or not, in the workplace with working with health promotion and wellness, occupational health and safety, employee assistance programs. really a lot of different places, and including our faith-based community programs. So this is why we really need to be preparing, whether it's social workers and nurses and counselors and all those other disciplines, we need to be preparing them to be ready to provide services wherever they see adolescents, young adults, and adults. So health professional training efforts have been slow but growing. There's been terrific support from federal agencies to educate pre-service professionals through the Health Profession Expert grants is one example. Of course, HRSA has behavioral health workforce development as well. And then existing workforce efforts, including those state grants and those kinds of more widespread systems level workforce development efforts. And those are very necessary, but they're insufficient for really scaling up and really preparing the workforce that we really need to be prepared. And so we need mechanisms to bring training to scale. And the goal really is to prepare those health professionals to be ready wherever those adolescents and young adults receive substance use and mental health services. So that really gives you probably a sense of what our initiative is about, what we're really trying to address, what we hope to work with you to do. And so thank you for letting me share that with you. And what I'm going to do now is we're going to talk more specifically about a national survey and preparing primary care professionals to be ready to integrate behavioral health services. So I am going to first introduce our presenters. They're also our collaborators and partners. And I'm going to start by introducing Ron Goldman. Ron Goldman is an innovator, tech executive, and social entrepreneur. Over the past decade, he has pioneered the use of gaming and simulation technology for learning and assessment experiences in health, behavioral health, and education. As Cognito's co-founder and CEO, Ron is responsible for setting the strategic vision of Cognito and leading its operational functions, including sales, marketing, finance, product development, and technology. Ron has served in the role of principal investigator and has co-authored several articles published in peer-reviewed journals. His work has contributed to 3 Cognito simulations being listed in the National Registry of Evidence-Based Programs and Practices, known as NREP. Our second presenter today, joining Ron also from Cognito, is Dr. Glenn Albright. And Dr. Albright leads a team of researchers at Cognito in evaluating the efficacy of role-play simulations. He is a clinical psychologist who received his PhD from the City University of New York in the area of experimental cognition. He is the former chair of the Department of Psychology at Baruch College and is actively involved in publishing how game-based role-play simulations can cost-effectively bring about positive changes in behaviors related to mental and physical health, with a particular interest in reaching large numbers of geographically dispersed people that comprise vulnerable populations. So it's my pleasure to have both Ron and Glenn with us to share their work. And I'm going to turn it over. We're going to start with Ron. Welcome, Ron.
Thank you, Tracy, very much. Happy to be here and share information about the work we do and specifically around this national survey that was done. I want to start maybe just very quickly for those of you not familiar with Cognito, to give you a little bit of information about us. We are a health simulation company, really looking at ways that we can leverage and harness the power of conversations with virtual humans to help improve health, whether it's social, emotional, or physical health. The main way in which we use conversation with virtual humans is around professional development of medical professionals, where we allow them to practice a conversation with a virtual patient that is coded to have a certain personality and a medical condition and a mental health condition, so they can really practice and build confidence and skill so they can better manage these conversations in real life. Substance use and expert and mental health has been a big topic of concentration for us. And clearly, we're talking about conversations where you have to go beyond the medical, clinical decision, right? You can know whether the person is at a right level of risk, but then you need to actually talk to them if it is to conduct brief intervention using motivational interviewing or do a referral to treatment. If those conversations are not well managed, the health and the outcome that we wish to see is not going to be there. So we have worked very hard in this area, and as part of what Glenn today will cover and myself collect a lot of data from users and are excited to share some of that with you, which really provides, I think, a really good overview of where these health professionals are today in terms of interest in this topic, in terms of the behavior. You know, do they screen? Do they conduct brief intervention? So that's what we'll do over the next kind of 10, 15 minutes, and then have plenty of time for questions to answer. So Glenn, I'll hand it over to you.
Thanks, Ron. The national survey by which we gather data was conducted between August 2015 and September 2018. It surveyed over 50 organizations nationwide, and that resulted in being able to capture survey responses from 676 healthcare professionals. The survey attempted vis-a-vis Likert scale items to get a handle on how competent or prepared healthcare professionals were to engage in an expert, and also their likelihood or behavioral intent to do such. These two attitudinal constructs were selected because, unlike knowledge items, attitudes like preparedness, competency, and likelihood predict behavior change. Knowledge items do not. We also asked them how many patients that they currently engage in these activities. Next slide. So participants completed a survey immediately prior to enrolling in one of Cognito's library of expert training simulations, in which numerous hospitals and other healthcare organizations license from us for use in professional development. The simulation takes somewhere between 45 to 60 minutes to complete. And next slide. And here we can see the demographics, and basically data was captured from 70% of those individuals who were a nurse or nurse practitioner and 30% physician. You can see the breakdown in terms of race and ethnicity, and most of them were female, 85%, with 14% male.
All right, so the first group of items we looked at, as Glenn talked about, is around competency. And you can see here on the slide the three key measures. We really wanted to know whether these health professionals, physicians, nurses, nurse practitioners, whether they feel prepared to do the different elements of the expert process. So you can see, for example, 57% say that they do not feel adequately prepared to screen patients for substance use or mental health disorders, or to provide them with information about the impact of substance use. Similar percentages around the use of motivational interviewing. So you see 64% of these people who participated in the survey say that they don't feel prepared to do that, to use motivational interviewing to really drive positive change in the behavior of their patients. And the same thing around collaboration with patients, which is such a core to what we want healthcare providers to do, right? Whether it's substance use or not, we want them to collaborate. I think when it comes to substance use, perhaps there's even a little bit more of a difficulty that these professionals report in terms of really be able to collaborate with them. So we very quickly saw in the results that the level of self-reported preparedness around conducting expert is pretty low. And then we wanted to actually also look at their kind of what we call behavioral intent, right? I mean, how likely are you to provide substance use or mental health screening, brief intervention, referral to treatment? And here it was interesting because, as you can see on the graph, the vast majority of 84% said that they are likely to do it. So on one hand, you can say, well, that's actually not a good thing. They're saying they're not prepared, but here they are saying that they're likely to provide it, and I would agree. At the same time, you can say, even though they're not prepared, there is a strong interest by these providers to do something about substance use and mental health. They are very much aware that it's an issue. They're very motivated to do it, but they are at the same time not prepared to do it well. So that was an interesting finding. But then what we also wanted to do is to look a little bit at their current behavior, right? So if you think statistically speaking, and you will see that as an image later on, but from a general population, 5% of people are defined to be at high risk, 25% are kind of a risky, harmful use, and should be engaged in brief intervention. So there's about 30% of the population that that providers, when they interact with them, should engage them in a brief intervention and referral. So we kind of wanted to know what are the numbers that currently these physicians and nurses are actually conducting screening with, brief intervention and referral. And you can see those numbers in the table there. And there were a couple of things that we found really interesting here. One is, when you look even at a physician and we ask them the question about how many patients have you screened in the last 2 months, right? It's a long period of time. And they say, the average was 17.6, so let's say 18. That is a pretty low number if you take into account that about 30% of the population is at a sufficient level of risk to require brief intervention or referral. And you see the numbers with nurses even lower. But then what was also interesting is kind of the ratio between these three, let's call them steps in a conversation, right? You screen the patient. If they screen at a certain level, you will engage in a brief motivational counseling. At that point, you may also engage in a referral to additional treatment. And if you look at the percentages, and you can see this in the text on the left, physicians engage 32% of those they screen in a brief intervention. That percentage with nurses was 55%. So nurses, with those that they engage with, engage half of the patients that they screen in a brief intervention, physician only a third. We don't know why. I think it's a great question. It's a question maybe, Tracy, you may have some idea about what that is the case. And you can see the same thing around referral to treatment. A very small percentage of those that get screened by physician, only 7% are being referred to treatment versus 41% with nurses. One theory we heard from a researcher that we share this with was that physicians tend to have a higher level of bias on the general topic of behavioral health, and kind of less of a belief that a referral to a different behavioral health specialist is the right way to go. That was one theory that was shared with us versus nurses that are less biased or has less of a stigma on those. I think that's an interesting point. We don't have enough data to validate that. But I think it's an interesting finding about the differences between physicians and nurses in terms of this kind of cascading effect that start from the screening. So those were the three key data points that we looked at. And this really brings us to some of the takeaways from this survey. Remember that the survey really looked at people before they went into any training, right? So this is bias of them engaging in any type of educational experience. This was done before they went in. So in terms of takeaways, there's really kind of, just to summarize what we have found, the majority of the participants don't feel prepared to really address the needs of their patients. Less than half of them feel prepared to collaborate with patients, but still a very high percentage, right, 84%, did report an intent to utilize such skills, that they are likely or very likely to actually do that, which again communicates a clear situation where you have a very motivated audience that is telling you that they want to do this, but they don't feel prepared in doing that. And then as a part two, what we just spoke about is that they really screen a fraction of the patients they see. You can see this image here that shows you kind of the general breakdown of the population between different levels of risk, right? This is where the 30% that I mentioned before came from. And then obviously the differences between physicians and nurses around those two topics. I don't know, Glenn, if you have any kind of additional inputs to put in. Curious, Tracy, your reaction as an expert in this area when you saw this. Is this kind of pretty much what is the understanding in the market, or were there kind of interesting findings here when you look through the data?
Yeah, thank you, Ron. Glenn, I don't know if you have any additional thoughts you want to share. I have a couple of observations just based on our experience.
Right. Really, no more additional thoughts than what Ron covered, but it's just really amazing to me that you have a lack of perceived preparedness or competency, yet you have an incredibly high behavioral intent to do expert training. So you demonstrated that people are willing to do this, they want to do this, but they don't feel adequately prepared. And that really underscores the need of this population and the importance of training that they need and want.
Yeah, and I can share with you a couple of things. We have conducted needs assessments over the years and have found similar findings, that there is a perceived need. There's motivation, a sense of motivation, a sense, that strong behavioral intentions. They want to do it. Some of the barriers that came up, at least in our needs assessments, were not feeling like they had ever previously been trained. So for the current workforce, whether they were educators or they were out in the field practicing, their formal training didn't include this kind of education. And then the professional development opportunities were not as frequent. They were going to various conferences, but this particular topic wasn't necessarily readily available at the association meetings that they were attending. So it was a bit of a lack of opportunity or access to training and other kinds of supports. The other thing we also have heard is that there was a lack of training materials already packaged, so that once they were able to get trained and feel confident themselves, how were they going to scale up training in their organization? What materials really existed that were publicly available, that had been tested? How could they adapt those materials, not knowing how to adapt them? How do they adapt them for primary care, for an emergency setting, for an FQHC setting, or a school? What are the common elements? How does it get adapted? And they didn't feel comfortable adapting them and didn't know where to get them. And that is actually one of the impetus for this project, was to bring a curriculum, a comprehensive curriculum that could be applied in many settings, and to provide that technical support by telephone and email to help guide them in crafting the training that they want to employ in their own organizations, or that they want to integrate in their academic program to train up those pre-professionals. The other thing that we have heard, going back to a different point that you made about low rates of screening and brief intervention. Screening is more likely to get done. We hope that's with fidelity and quality. We don't always know, but that's the most likely piece of the expert approach to get done, and it's not easy to do, and there are barriers to doing that, which keeps screening rates lower than we'd like. Delivering the brief intervention is like a whole other set of barriers and challenges that are different for different providers in different contexts. So primary care providers, we've often heard, feel completely overloaded and overwhelmed, don't know how to fit it in. There's a lack of support, maybe availability of a nurse or a social worker who can help provide that, or a medical assistant who could actually do the screening and then allow the physician to do the BI, so they're not doing all of it. There's lots and lots of barriers. In fact, what I can point folks to, and we can put this up in the Q&A document, and if we can find this to put it in the chat box quickly, we will. We actually did an environmental scan with interviews and site visits and a massive review of the literature and produced a report for the Assistant Secretary for Planning and Evaluation, or ASPE, which goes through and presents, kind of lays out the barriers of why screening and brief intervention and getting that hump from screening to brief intervention, and then the RT piece aren't happening with the rates that we would like them to. So we'll try to point you to that resource. There's an executive summary that will be probably very informative without reading the whole thing. But what I'm seeing you present here is similar to what we have observed on the ground over the last 10 years. So I'll just stop there and see if you have any reaction to that.
No, I mean, it's similar to many of the sites where we implemented. That's kind of been the same, right? We know we need to do this. We have physician nurses, physician assistant asking for it. We're looking for a way to give them not just the clinical skill, but also the actual conversation skill to be able to do the brief intervention, the motivational interviewing skill. So we're hearing the same thing. But I wonder, Glenn, maybe just a quick question for you. Does the data that we have collected show that these professionals are seeking the clinical skill at the same rate as they're seeking the conversation, motivational interviewing skills? Is it at the same level, or do you really need one more than the other?
That's a great question, and certainly there is a need and a desire to learn about the availability of validated screening tools and how to correctly apply them. But beyond that, and perhaps most importantly, is the ability to effectively meet the patient at where they're at, to apply MI skills in setting up an environment where they patient feels safe to talk, to be able to gain the competency or the preparedness in engaging in a collaborative treatment plan, all leading to the self-confidence increasing. So without that competency and without the self-efficacy, you're not as able to do that, and that's exactly what they need to learn.
Thank you.
Yeah, thank you for bringing that up. One of the things that we're doing in parallel to your efforts to evaluate workforce training using simulation is through our national initiative. We are also conducting a number of different evaluations, as you can imagine, looking at preparing students in the classroom, which could be virtual or in classroom, looking at preparing the educators, the instructors and faculty, and the preceptors and field supervisors and field instructors that provide that supervision to students. And we have available, if anyone is interested, we make available our measures. So if you're wanting to do education and training of a particular group, you can choose measures that tap into exactly what Glenn and Ron are talking about self-efficacy. These measures include measures of knowledge about substance use prevalence, knowledge about the use of the brief negotiated interview, and the use of motivational interviewing strategies. It also includes measures of attitudes, which are often a little, they're the weakest link among measures. It's difficult to change attitudes in a short period of time, but we have used two measures. We have had some success with some and not with others. And we're still sort of looking at the use of those measures. So I always like to tell folks, be really thoughtful when you think about attitudes measures, making sure that you're aligning any measure to what you believe that you're training and you're going to influence as a result of your development. But we have those measures. In addition to that, we have the self-efficacy measures looking at their confidence in being able to deliver screening and brief intervention for different types of substances with young people. We also have these measures for adults. Their readiness, so there are questions built in for how ready they feel. And we also have perceptions of competence. So they're, again, this is perceived competence in their own skills and abilities. And we also have skills measures. So in addition to skills measures such as scenarios that allow people to really kind of reflect on what they've learned, to be able to identify that BNI and MI congruent response or in the conversation. We have those kinds of measures as well. And in addition to that, we pair that with the wonderful competency assessment that you have built into your simulations, the SBI with Adolescent Skills Assessment and the SBI Skills Assessment in the at-risk at primary care. Those are terrific and really are great measures. So I encourage folks to think about measures in conducting your own evaluation when you do training so that you know what you're impacting. And I would say, if you need some technical assistance around, designing your training or selecting measures, I'm certainly glad to give you some, telephonic support in doing that. Clearly, we still have a lot of work to do. So, together. All right. So, I think what we'll do is we will move forward, and I want to talk to you now a little bit more about the training resources available to you. So as you're listening and we're hearing Ron and Glenn talk about the need to prepare and get people comfortable and ready and confident, and when they have these intentions, what we're trying to do is complement the SBI with adolescent simulation with a even broader set of toolkit materials and resources that can be paired together or used separately to implement your own workforce development efforts. So let me give you a couple of snapshots of that real quickly, and then after that we will take some questions. So go ahead and get your questions in the chat box if you have any. In the questions pane. Okay. All right. So the Adolescent Expert Training Curriculum and Toolkit. You can go to our website, again, theexpert.webs.com, and you can click on Curriculum. And this is where you're going to see more information about SBI with Adolescent Simulation and more information about our Learner's Guide to Adolescent Expert, as well as all sorts of other materials that you're going to get a sneak peek of now. So at a high level, the Learner's Guide includes modules that cover all components of screening, brief intervention, referral to treatment and follow-up, and motivational interviewing strategies, as well as that foundation of why even do substance use screening and brief intervention with youth, the prevalence of it, the rationale of it. These are comprehensive modules. With this Learner's Guide, there is a companion slide deck. Think of it as an accordion. It can be as as expansive or as constrained as you want it to be. It's not designed for you to deliver all of it. It's designed as a menu of choices that you are going to be picking from these modules what you want to train others on or train yourself on. So that is how it's set up, and it has those evaluation measures that I was mentioning that are available to you, which we've done psychometric testing on and could share a poster on those psychometrics if that is something that you would like to request by emailing us. Now, the components, each module will have learning objectives. So it's very clear when you're setting up your own training, you've got your learning objectives, you have suggested readings and resource materials. It's going to have sample conversations and dialogues and role plays and all sorts of wonderful tools, including like your brief intervention observation sheets where you're doing dialogue and dyads and triads to kind of check on the fidelity of how this practicing is going. So really, we hope this is somewhat of a one-stop shop to get you started and sustain your efforts over time. So you can order an electronic copy at no charge by going to the curriculum website and requesting a copy by linking to the icon on that page. On either icon, whether you want just the instructor's guide, which is for educators or trainers or whomever, it's for everybody, you can, from that link, you can request all the materials that I had mentioned. You just select the ones that you want and don't select the ones that you're not interested in. You can also order a hard copy. We make these available at cost of whatever it costs to print it and ship it. So it's not something that we sell and make revenue off of, but we do want to make it available to you. And that is a fillable form that you basically email. There'll be instructions there, or you can fax it. Also, I want to give you just a sneak peek here. So each module, as I mentioned, has these learning objectives, and they're set up very similarly. You're going to have your learning objectives and your suggested readings. There are hyperlinks to many of these resources on the curriculum page, and if you can't get them, you can generally request them through resource or purchase them. Most of them we try to make are publicly available, if at all possible. That is the goal. So many of these are freely available and easily accessed from like PubMed. And it will go through, the screening and multiple screening tools. It's going to go through the brief negotiated interview. It's going to go through the MI skills. It's going to go through best practices and referral and follow-up. And it's going to go through the treatment options and sort of what is the current state of what is recommended around treatment for adolescents and young adults. Here is a snapshot of a sample interaction. So you have a scripted sample interaction for almost every screening tool with interpretation and highlights of which skills are being utilized during that sample interaction. We have varied settings, so if you're in a school, you're in medical, you're in juvenile justice, you're in a variety of places. The goal is to try to help you envision these sample interactions. And then even if you're not in that setting, try to just, focus on the delivery of that dialogue. What does that look and feel and sound like? And helping folks get the words and make it their own is really about building that self-efficacy and feeling comfortable and prepared. And there are tools like this that walk you through scripted brief interventions with adolescents, kind of noting what are the elements of the brief intervention, what is that particular component of BI, or is there an MI skill that's being utilized here? And it really breaks it down, and you can train around each piece. So if you're training around using your readiness ruler, which we have, you're going to have materials that align directly with how to train around that, or how to use summarizing and thinking, which is, part of being MI congruent, and when you're weaving in MI into your brief negotiated interview. All of these tools are readily available in the learner's guide. And then another example is the role plays. I mentioned the role plays. There are role plays around screening, role plays around brief intervention, and role plays around referral and follow-up. And then case studies. We were it was very generous of our colleagues to allow us to use their case studies they use at the BNI Art Institute. So if you've seen these before, there's a whole host of case studies that they allowed us to integrate into our guide that you can benefit from. And then in the appendix of the Learner's Guide and online, we have all sorts of other tools that you can use in both practice and in training. So I hope you'll take advantage of looking at those, including these wonderful pocket cards that you can easily print and laminate and use in your practice or in training. And take advantage of all the online materials, the literature, the screening tools you can download, policy statements from the American Academy of Pediatrics, all sorts of great things that are available right at your fingertips. And if you'd like to take another preview, a more in-depth preview of the Learner's Guide and the Toolkit, we have a recording for you. You can share it with your colleagues, go through it yourself, and get a better sense of what these materials are that are available for you to do your own workforce development. So I'm going to stop there and just remind folks that you can ask questions in the questions pane. And I'm going to go ahead and take a look and see what questions that we have here already. Let's see. So the first question is, how can I learn more about the curriculum development for social work education? Well, a lot of information about the curriculum development, we can tell you more about how ours was developed for social work, and we can also provide you a telephonic technical assistance to give you some guidance on how other social work programs are implementing and integrating this content into their curriculum. We know a little bit about the courses. They're integrating them in terms of at all different levels of education, undergrad and grad. We know a little bit about the methods that they're employing and about some of the ways that they're embedding content in different classes based on what aligns with the syllabi, and also how they're integrating into, let's say, standardized patient labs or role play simulation labs. We could talk to you more about that specific to your program. Let's see. The next question is, has there been any successful integration of SBIRT in middle and high school nursing offices? Yes, I have talked with a number of sites about this in their clinic or the nurse's office, and it is, I can't speak to in terms of the how successful at a national level it has been. I am not sure if anybody has done a systematic review of the implementation in clinics, in schools, specifically to nurses, but there has been success with integrating brief screening tools into whether it's physicals or it's other kinds of processes that they do as a part of their screening. If you'd like to learn more about what we have, our experiences with this and what we've learned, or talk a little bit specifically about your setting in your clinic with your nurses, again, you're welcome to contact us. We could set up a TA call to talk about that. Okay, the next question is for Ron and Glenn. This question is, if I heard you correctly, your survey was done before they received a Cognito module. Were they measured after that experience? And if so, what were the results?
This is Glenn here. Great question. In all the simulations that comprise our library of SBIRT training, there is a pre-survey that gathers baseline information. They take the simulation, and it's immediately followed by a post-survey, and then anywhere between 2 to 3 months later, a follow-up survey. In any of the simulations, the data revealed that there was a significant increase between pre and post and pre and follow-up in learners' preparedness to engage in SBIRT training, their preparedness and self-efficacy to engage in collaborative conversations with their patients, and the likelihood that they would have these conversations. Also, in examining changes in behavior from pre to follow-up, there were significant increases in the number of patients screened, the number of patients talked to, where MI was used in developing a treatment plan, and lastly, the number of referrals that were made. So very happy and pleased to see the impact of these simulations and how that impact is sustained over time.
Thank you, Glenn. We also, in our analysis, we've been looking mostly at the knowledge, attitudes, readiness, confidence, competence, and skills. And we demonstrated with the implementation in a field trial of the simulation as a standalone educational and training intervention. We also demonstrated changes on those dimensions. And we have expanded our evaluation in this phase to include looking at the behaviors, the practice behaviors, looking at practice in the last 2 months, aligning it actually with the measures that Glenn and Ron, you use. And so we'll be analyzing that data in the coming months. This is our first round of collection of practice data, but we definitely have and presented a lot. We have presentations and posters we can share with any of you about some of the findings from our national evaluations of the curriculum.
Yeah, and Tracy, just to kind of clarify something for some of the audience, the NORC kind of expert solution is really a combination of a Cognito simulation, right, the SBI with adolescent, plus materials that you discussed here around supportive implementation and other materials that can be used in person. And then some of the other solutions that we have are other online and mobile simulations where the patients are not adolescent, but they're adults, or where the conversation is not about substance use, but about mental health, suicide prevention, et cetera. Just to clarify, that people don't think that there are two separate offerings here. There's really a great collaboration between NORC and Cognito now for, I think, 3 or 4 years around combining these simulations with additional support and technical support from NORC, which has been really great.
Yeah, thank you. Likewise, thank you for sharing that and mentioning that to make sure folks have a sense of how this all works together. Let me ask you a question about the paper you're providing. There's just a question of clarification about the white paper on your research and when that will be available and how to access it. Did you want to say more about that?
Sure. Yes, and maybe even before I talk about it, I do want to recognize the other co-author of the white paper, which is Indepth Preview, who's a former dean at the Graduate School of Johns Hopkins School of Nursing, who's been involved in authoring the paper together with Glenn. So I want to recognize her contribution and thank her for that. The white paper is available. It's available on the Cognito website. It will be part of the follow-up email that everybody on this webinar will receive. So, you know, we hope everybody will look at it, find it valuable, and if you have any questions around the data, the contact information for Glenn is shared on these slides, but also in the actual paper. And Glenn loves very difficult questions about statistics. It's his favorite topic. Okay.
Thank you for that. Yeah, thank you. So, and thank you all for your questions. Thank you, Ron and Glenn, for sharing your work and letting us learn more about what's coming in the paper and some of the future evaluation that you're going to be doing. And I'm looking forward to seeing the results. And for those of you who we didn't get to your question, we're going to put a Q&A document together for you, post it to the website, and make sure we try to respond to as many of those as possible. In our last few minutes together, I'd just like to remind folks that all the PowerPoint slides are available on the website. And after the webinar concludes, you'll receive a follow-up email from us that contains instructions for watching the on-demand recording, obtaining a free certificate of attendance, and completing a short evaluation survey. You'll also see some of the new and upcoming dates for this webinar. So if you have colleagues you think would be interested in joining one of the future sessions, make sure you send them to the website, because we're going to have future dates for this webinar, and of course encourage them to sign up for other webinars as well. And I also want to mention that we're in the follow-up email, you're going to have a very brief evaluation survey. And this is not your typical sort of training satisfaction kind of survey. This is actually a really meaningful survey, but very brief. And what we're really trying to get a sense of is really evaluate the kind of professional development that we're providing you, making sure that what we're providing you sort of meets with what you're interested in, getting a sense of what kind of things you're doing around screening and brief intervention. And we really do look at our data to help guide us in our work. So please do that, complete that. And in a couple of months, we will also follow up with you again. So with a very, very brief follow-up survey. And again, we would love for you to complete that. We do look at those as well, and that helps guide us on what sort of the impact we're having even in the future. So with that, I'm just going to say thank you to Glenn and Ron for this excellent presentation. Thank you very much. And then remind folks that if you wanted to take advantage of some telephonic technical assistance session, or you want more information about something, you can contact me or the expert team. And with that, I'd just like to say thank you all for attending, and thank you to all of the collaboration with Cognito and, of course, to the Hilton Foundation for supporting this work. I hope you have a good rest of the afternoon. Thank you.